Hello there. I'm going to be covering the content from chapters 31, 32, 33, 34, and 35 for Maternal Child Nursing, Nursing 396. For this content, we'll start covering the theorists regarding the different age groups and development from one stage to the next. Freud covers the psychosexual development of children through ages of infancy to adolescence, starting with the oral stage, and we've talked about that, where patients in infancy are gratified through oral stimulation. That's where sucking and feeding are the most important needs to be met in infancy, and that's where infant clients can be soothed, is by focusing on their oral satisfaction or gratification. As a child develops into toddlerhood, that is where Freud has discovered the anal stage, and we can see that in practice when we see that toddler patients or toddlers in general are starting to control bladder and bowel by having sphincter control. And that is where toilet training is sort of an expected activity in toddlerhood, as those clients are in what Freud defines as the anal stage. Preschoolers in the phallic stage, and that's where preschoolers are starting to realize and realize the differences between male and female anatomy. And that is where you'll see preschoolers potentially investigating themselves, and focus there is to not bring awareness to, but just acknowledge that that's an expected activity at that age. School age, latency, period of sort of quiet development according to Freud, whereas at adolescence, developing back into a genital phase where adolescent children are expected to be progressing through puberty with primary and secondary sex characteristic development. So that coincides with what we would expect adolescents to be developing at that stage. As we go to the right, we see psychosocial development as defined by Erikson. And there are 8 stages of Erikson's psychosocial development as he understands, but we will only discuss 5 of them related to childhood. So each stage has 2 components, the first being the favorable, the second being the unfavorable. And the progression of a child to the next stage is determined by their resolution of the conflict they endure between the two. So with trust versus mistrust, with consistent loving care, the result would be that the child has faith in their caregivers. If their needs are not met, they may be settled in the stage of mistrust, where they don't trust their caregivers if their needs are not being met. Autonomy versus shame and doubt in toddlerhood is where children are trying out new skills, imitating others. The result would be self-control and willpower. Whereas if they are not allowed to develop that autonomous ability, they may result in shaming themselves or doubting themselves as being able to complete tasks. Preschoolers in the initiative versus guilt, that's where children are exploring their world through senses. They start to have an inner voice, and the result is giving them direction and purpose. And if they're not supported through that desire to be initiating activity, they may go through a stage of feeling guilty about their ability to develop on their own and be contributive to the world around them. Industry versus inferiority. This is in school age children, where they are ready to be workers and producers. They start to develop social relationships. They want to be able to perform and complete tasks. And if unable to be supported in that and successful, they may find themselves feeling inferior. And then finally, in identity versus role confusion, This is where adolescents are going through physical changes and trying to develop a self-concept. And this is where they're developing identity and independence. So supportive of that in that stage, helping them to complete that task and being resulting in the favorable identity where they're confidently identifying themselves and who they are. Cognitive development, theorized by Piaget, where these are age-related changes that relate to mental activities. So intelligence enables individuals to make adaptations to the environment, and that will increase their probability of survival. So through behaviors, individuals establish and they'll maintain equilibrium with the environment. The sensory motor phase is where the reflex behaviors are still intact. Children are curious, experiment, and they enjoy the novelty of experiences. In sensory motor, they are really experiencing their environment through their sensory capabilities. Developing then into pre-operational, where especially in toddlerhood, seeing that toddlerhood and preschooler, where children are egocentric, they're unable to put themselves in the place of another person. So really focusing on that egocentric thought. And this is pre-operational in that they're not able to begin logic. So it's more intuitive feelings and thoughts. Concrete operations beginning in school age children. This is where logical and coherent thought starts to develop. They have socialized thinking. They can consider other points of view. And in adolescence, we see the beginnings of formal operations where individuals can deduce and think abstractly, and this is where children are starting to be capable of creating hypotheses, and this coincides with the academic expectations of children as they develop from thinking intuitively to beginning to apply logic to situations, and then in adolescence being able to deduce and abstract, so sort of what they're expected academically coincides with the levels of cognitive development. And then as we progress to the far right column, looking at moral development, no moral development quite yet in infancy. We see in toddlerhood that children are, they do things right and wrong according to punishment and obedience orientation, meaning if they get in trouble for something, they think that's bad, and if they don't, they think it's good. They then end up developing in school age children. We see the conventional phase of Kohlberg's moral theories, in that children are basing their actions on rules, showing respect for authority, maintaining social order, and then we see in post-conventional, we see that behaviors are defined in terms of children's individual rights and standards. And there was an emphasis on changing social norms dependent on societal needs and rational considerations. So this is the phase in which society has identified that applying social or applying your social ethical principles to guide decisions and conscience is at this level, and that few actually ever reach this in society. On the next page, we are discussing immunizations. So like I said in class, that first 18 months of life, infants and children are receiving quite a few immunizations. We do see that starting at 1 month of age, children are getting, or the expected plan, according to the Center for Disease Control and Prevention, recommends the second of the 3 hepatitis B vaccinations. So we see that the first one is given at birth, second at 1 month, and then if you scroll down to 6 months, we see the third of hepatitis B vaccination, which would complete the series. The second and fourth month visits for infants include 5 immunizations, the first of which being the rotavirus vaccination. Rotavirus being a potentially fatal GI infection that can affect infants, especially those with previous medical conditions, so congenital heart defects or prematurity. It can affect those children more severely, resulting in severe dehydration. So there are now immunizations against that infection. If you look down at the bottom, the vaccine can be either Rototec or Rotarix. Rototec would require 3 doses. Rotarix would require 2. The series of rotavirus vaccination must start before 15 weeks and be completed by 8 months of age. So not every child ends up getting the complete series, but the hope is that if a child is at greater risk, that parents are adherent to this schedule. Other immunizations offered or required at 2 and 4 months are the DTaP, which is the diphtheria, tetanus, and acellular pertussis, the Haemophilus influenza B, pneumococcal virus vaccination, and the inactivated polio vaccine. You see that those are all repeated, DTaP, Hib, and PCV again at 6 months, where the inactivated polio vaccine is given, that 3rd dose given at 12 months. We see that as of 6 months, patients are eligible for the annual flu vaccine, and you will see that yearly going forward from the 6 months. At 12 months, we have the introduction of hepatitis A, varicella, and the MMR vaccination. And then you see the second of the 2 hepatitis A vaccines given at 15 to 18 months. An additional DTaP given at 15 to 18 months as well. And then starting in years, in 4 to 6 years, we will see the second of the MMR and varicella. We see the 4th of the IPV, DTaP, and yearly influenza. I have it listed every year, but yearly influenza is recommended for children. And 11 to 12 months, we see the introduction of the meningococcal, HPV, and then we see immunization switch to Tdap, which is given annually, every 10 years for going through adulthood. The HPV vaccine is recommended to start at the age of 11 to 12 because if given after the age of 14, patients would require 3 doses. Prior to the age of 14, patients are only required to receive 2 doses. Again, yearly influenza, and then meningococcal again at the age of 16. So that's a quick review of immunization schedules. Here's another format for that. As we progress on, we see fine motor and gross motor for the first 12 months of an infant's life. As we start the discussion of specifically infants. We see in months on the left side and then the activities on the right side. 1 to 2 months, we're still seeing those rudimentary reflexes present. We do see prone head lift, meaning if a child is placed on their stomach, that they are able to lift up their head slightly at those first 1 to 2 month points. Slowly getting stronger as the child's head and neck are controlled more in line with the body. I did discuss in class about the head lag. So if you were to hold the hands of an infant placed in bed supine and pull them up, the head should lag behind when first born, or expected to be lagging behind, whereas as they develop over the years, we start to see the disappearance of the head lag in the 5-month stage. We do want to see that head lag disappear because we want to see infants starting to control their head and neck. So we're looking at that. If we do see the head lag continue and persist, that would be worthy of providing the child or encouraging the family to seek a specialist investigation, or maybe even looking at the potential for some cognitive or neurologic delay. Being careful not to assign that title to that infant, but if that persists too long, making sure that the family has follow-up with a specialist. We can see that in the 4 to 5 month period, we see infants starting to put their hand to mouth, rolling from tummy to back, reaching and grabbing voluntarily, using the palmar grasp, where they're grasping for things using the palm as opposed to their fingers, which is called the pincer grasp. So sort of the rudimentary palmar grasp starting and developing into pincer grasp in the 8 to 9 month stage. What's important in these 4 to 5 month period is that if infants are able to reach and grab and bring hand to mouth, that dangers around the home should be eliminated, and children should be monitored, because this is where they could grab at mobiles hanging over their bed, or they could put things in their mouth that are not edible. So being careful to monitor children and to safety-proof the house. 6 to 7 months, we see the first tooth is developing, so solid foods and adding iron-rich foods for infants is important. Infants can hold their bottle at this stage. They can sit and put their hands in front to a tripod sitting, which we start to see some trunk strength, rolling from back to tummy, transferring hand to hand, repeating sounds, laughing. And this is where object permanence and stranger anxiety are pertinent. We were seeing that infants do have stranger anxiety really as a result of the not fully grasping the idea of object permanence yet. So infants thinking that when their parents leave that they are gone forever. So that is why that is important. 8 to 9 months, infants can sit well, crawl and pull, purposefully dropping items, understanding the meaning of the word no, responding to simple commands, and that beginning of the pincer grasp. 10 to 12 months, seeing that infants can feed themselves finger foods, stand and walk with help, which puts them at greater potential injury risk throughout the home, so making sure the home is safeguarded against any kind of exposure. And then they can build a 2-block tower. Believe it or not, important to remember that infants, progressing through infancy and toddlerhood, you will see NCLEX questions based on how many blocks a child can build a tower of. So you'll see this on slide 8 in my notes, but at 15 months, a child is expected to be able to, 12 to 15 months, be able to build a 2-block tower and throw a ball. They will get their forward momentum and, expected to potentially fall forward as they throw a ball. We'll see at 18 months, they can build a 3 to 4 tower, or cube tower rather. This is where they start to develop a better sense of balance, so they can throw, and the expectation is that they would not fall as they're throwing forward. We see at 24 months, expectation of 6 to 7 cube tower, seeing that children at this age can start to kick a ball or turn a doorknob. And then at 30 months, seeing the 8 cube tower. They can jump with both feet and tiptoe steps, and they can hold a crayon. So those are all really exciting developments. We'll now progress to infancy. So you can see on this slide, what I'm going to cover is the important things that I will discuss are on the right side. On the left side, you're responsible for that information, so I recommend you read through it and study it. I have kind of taken out the high points on the right side. So we see that nursing implications for infancy, birth to 12 months, are going to include things such as nursing implications are going to be safety, prevention of infection, and incorporating the child into the family. So safety being, we're looking at safeguarding the home, preventing infections with all the immunizations that children receive. And with developmental awareness, we're looking at supporting the family through knowing expected milestones, reassuring them as the child progresses through, and then encouraging interaction with the child. So encouraging parents to hold the child, touch the child, keep them warm, eye contact, providing a clean, warm environment, which means, life is simple, just keeping them warm and dry, and then, holding tightly, providing them, helping for them to develop the trust of their environment, according to Erikson. Wellness promotion includes providing good nutrition, preventing infection, and promoting sleep. So nutritional support at this stage should include scheduled feedings, that breast milk is recommendation for the first 6 months, solid foods starting with rice cereal as it produces the fewest allergic responses, infection prevention, including immunizations and good hand washing. We do see that the most common causes of death in infancy are suffocation, so discouraging co-sleeping, and extra bedding or blankets, discouraging that. MVCs being motor vehicle crashes, so making sure that families are aware of the recommendations for safety seats in the car. Drowning is a great risk, so making sure that if there's a pool at the home, making sure that appropriate alarms and locks are in place, and that bathing is an accompanied event with an adult present. Reviewing that crib rails needing to be up when a parent walks away, that including the diaper changing station as well, that parents and adults are there holding the child with one hand on the body. If they look away, to make sure that children don't roll off the crib or the changing table. And that's important in the hospital too, that reminding families that when they put the side rail down, to make sure that they don't walk away. Outlet plugs, making sure that covers are on outlet plugs. Please review the child home safety checklists in the book. And this is a stage at which, late in the infancy, closer to 12 months, that limit setting rather and discipline start to become important to identify for the child what is right and wrong, so that you can keep them safe. As we move on to toddlerhood, we see the nursing implications in that play is an effective tool in building rapport with patients. So really trying to start out with playing with the child and establishing a relationship with them. We do see that teaching the child and family about the hospital experience, allowing parents to be present, is important. Explaining experiences in a calm voice, using play to alleviate anxiety, using short, simple instructions, comforting the child after pain, and encouraging parents to actively participate. And this is where I find it really important to allow parents to be the support and the love for the child, and not having the parent participate in any of the discomfort producing or pain related to any kind of experience. Children are in the pre-operational phase, so we do see that toddlers cannot think in terms of operations, but only on their perception of an event. So we can't be expecting children to understand cause and effect related to their health experience, or any kind of communication that we provide for them. Wellness promotion being, eliminating the risk for respiratory and parasitic infections, so making sure that hand washing is common practice. Especially if these kids are in daycare with siblings in daycare. Children are putting a lot in their mouths and touching various things that can have infections easily passed that way. So nutrition, important to avoid food as a reward, don't overserve or expecting. So really just trying to keep a standard plan of eating. Expecting sporadic eating. So this is a stage in which practitioners will commonly look at a child's intake over the course of a week versus day by day, because children do in this stage experience physiologic anorexia, meaning that they have decreased nutritional needs. They're not actually growing as fast as they had been in the infancy stage, and they may have decreased appetite. They're less likely to try new foods, so they may just decide that they're not hungry and don't need to eat much that day. You also see this inpatient where children will food strike, and that is really just, where it's just a natural response to being out of control. They then feel like, the one thing they can control is saying, I'm not hungry, I don't want to eat, if they are eating by mouth. So looking for that and really monitoring height and weight in this stage to make sure they're continuing to stay on track. Safety in this stage, important things to be remembering are car seats, toy safety. So in toddlerhood, making sure that toys are not choking hazards. There's a good barometer at this phase to make sure that toys don't fit through the hole of a toilet paper roll, and that's a good way to know if something is too small for the child at this stage to be playing with. They are increasingly mobile, and that puts them at risk of getting their hands on things that are unsafe, so making sure the home is safeguarded. Children are starting at the end of toddlerhood to understand causal relationships. Object permanence, they can't find something when it's lost under a blanket, for instance. If a practitioner holds something and then hides it, they can't find it, but they know it still exists somewhere. So they're starting to have a less severe feeling of stranger anxiety. So they know that if their parent leaves, that the parent isn't gone forever. They may not be able to find that parent or the toy, for instance, but stranger anxiety is starting to lessen for this age group. Domestic mimicry, so whereas you see at the top parallel play is an activity that's toddlerhood, domestic mimicry as well. You can think about the child at the daycare center or preschool starting to play with computers and phones and pretend kitchens and those kinds of things to mimic the domestic activities of their caregivers. They're starting to develop voluntary control of elimination and control of the sphincters, so that is when toilet training becomes a possibility. Anterior fontanelle should close at 18 months. And if a child at this age is exposed to, has an accidental poisoning, important steps for these children is to initially assess their health status. Then, so it's assessing the child ABCs, terminate that exposure, identify what it was that they were poisoned with, and preventing any more absorption. So it's going to be really important for these kids to also contact poison control. So that is an important step. Here I provide you, because the child in toddlerhood is in this stage of preoperational thinking, that we do have the preoperational characteristics on page 870 in your book, and I put some of those terms here just so you're familiar with them. So in preoperational stage, we see children in the egocentric phase, so the inability to envision other points of view. Animism is the feeling that they attribute lifelike qualities to inanimate objects. This is where they are really important to have sort of a loving, a special friend or a blanket, that kind of thing that creates comfort for them. Magical thinking is the idea that they believe that their thinking causes something. So that can really result in some guilt feelings at this stage if they think something bad about something, that something bad will happen. So sort of that reassurance that ideas are not in themselves bad. So that's kind of the loose definition of the term magical thinking. And then they cannot understand that a different presentation doesn't change something. So meaning, if you have a tall glass of water and you pour it into a short glass, that amount is the same. At this stage, they can't understand that. But they believe that if they present something differently, that it changes inherently, which is, of course, not true. But we know that children at this stage can't understand that. So this is sort of a helpful tool to understand. At this stage also in your book, they do stress the importance of understanding iron absorption, or rather, increased lead absorption. So lead poisoning, you do see a lot of questions related to lead poisoning in this age group on NCLEX questions. So I did want to touch on this. Lead absorption or increased lead absorption and lead toxicity or poisoning can affect different systems of the body, including the hematologic, renal, and neurologic systems. So with hematologic, we see the interference of the iron, or the lead rather, with interfering with the synthesis of the heme molecule, which could result in an anemia. We see it affecting the renal system in that it damages the cells of the proximal tubules and can result in impaired calcium function is the main outcome of that. So can affect bone growth. Neurologic system effects do increase the membrane permeability. So there is the potential for increased intracranial pressure, tissue ischemia. So important to know the effects of that. We see distractibility, impulsivity, hyperactivity. And on the right side, you can see that high dose exposure can result in convulsions, coma, and death. So where this might end up being something you see in practice is that the child that comes in that has development of these kind of symptoms and not sure where to trace it back to. So really lead is not something we see much in today's homes, but people living in older homes with lead-based paint or even lead exposure through soil can produce exposure for children. In practice, knowing that if children present with these sort of symptoms and there's no, we're in a phase of trying to rule out or identify the culprit, labs would be drawn for a child, and levels of 45 micrograms per deciliter would indicate the necessary intervention of chelation therapy, which is intramuscular injections. And what happens is the chelation effect binds with the lead in the systemic circulation, and then the child would then excrete the lead. The chelation treatment does not work for bone deposits of lead, so those are unfortunately permanent. So that is the intervention for lead poisoning. As I skip ahead to the preschooler, we see this as being the child 3 to 5 years old. Nursing implications include knowing that the child at this stage is curious, they're starting to communicate, so they have frequent use of the word why, lots of questions. Play is useful in developing relationships with these children. Through play, preschoolers are learning about their environment, relationships, and this helps them define their social expectations. This is where associative play is common, and where children will start to group play, but typically without any rules or expectations or roles. Wellness promotion includes school requirements for immunizations, since these children are starting to be in the school environment. I have nothing written for nutrition. I'm not sure why, but I think that we're, not I think, but for this stage, we're really looking at continuing to offer a variety of foods, scheduled meals, and making, healthy choices, including, the My Plate balance of fruits, vegetables, proteins. Still encouraging consumption of milk at this stage. Gross motor, we see walking, running, climbing, and jumping. Fine motor, we're starting to see children able to draw and dress themselves. And the dressing themselves is getting them ready to be ready for school. So this is where you see encouraging families to prepare for that extra time required for the child to independently be able to dress themselves for school. And that is supporting their initiative in Erikson's stages. This is where you see the child where they may have shoes on the wrong feet, and you can identify that they are probably dressing themselves. Superego and conscience, really starting to look at beyond themselves, so learning right from wrong. Safety is that they are impulsive and they're able to walk, run, climb, and jump, so potentially injuring themselves. The things that they learn about safety are going to be lifelong, so we can understand that. Magical thinking, we talked about this before, that belief that thoughts are all powerful, and this may lead to guilty feelings and responsibility of bad thoughts. So reminding the child that their thoughts are not causing outcomes. In this stage, we have children in pre-operational and pre-conventional, meaning that they understand that if they are punished, an action is bad, and if not punished, an action is not bad. Disfluency is common in this phase or the stage of life, and that meaning that children are their voice can't quite keep up with their brain, that they're understanding and learning things, but they can't speak it as quickly as they're thinking it, which means you might end up seeing evidence of what looks like stuttering. It's actually common in the ages of 2 to 5 years and termed disfluency, whereas if we start to see stuttering after 5 years, there may be the sort of red flag to encourage the child to participate in some sort of maybe potentially some occupational therapy, or looking to see if there's any deeper roots of the reason for stuttering. Whereas before, in the 2 to 5 years, we're expecting that. School age years, this ranges from losing their first tooth to puberty, which is a wide range of experiences. So there's a lot going on in these stages. So health promotion is super important. Wellness promotion, so encouraging healthy lifestyles. Hygiene is important at this phase as children are starting to develop, progress through puberty, which may result in, or will result in the development of, the starting of sex characteristics. So looking at the potential of starting periods at this time, menarche. So encouraging children to be prepared for that and having appropriate feminine hygiene products available to them. Regular checkups are important. Sleep patterns are important. Physical skill play. Kids at this age are encouraged and commonly engaged in board games because of their lengthened attention span and their interest in team sports. Concrete operations is starting in this phase where children are able to use thought process to experience life, and that coincides with their experience in academics. They're starting to see things from other points of view, making judgment based on reason. They are starting to understand the concept of conservation, so that the representation of something with the cup experiment, the tall skinny cup and the short fat cup, does not inherently change the volume of what's in the cup. Pedestrian and passenger safety, this is where scooters and bikes are commonly used, so making sure children are wearing helmets. We do see the identification at this age of attention deficit hyperactivity disorder. This would be evidenced by inattention, impulsivity, and hyperactivity. Knowing that behavioral therapy, environmental manipulation, and appropriate classroom placement are recommended first interventions. Pharmacologic therapy is a potential intervention for children diagnosed as such. But knowing that there are side effects from those medications, you'll often see children that are receiving stimulant medication for ADHD or ADD that they they don't eat as well, so they're having some eating problems. They have not interested in eating, so you may often see children on stimulants paired with a medication to help support their desire to eat, and I'm drawing a blank right now. So appetite stimulant, rather. So that would be something you may see paired with a stimulant. So their social network is expanding at this stage, and they're often participating in sports and activities. Concrete operations, since we are the school age, we're seeing concrete operations start to develop. So we're seeing the child can think logically about concrete objects. They can add and subtract, and they understand conservation. So this is, we're getting into higher level concrete operations. Adolescent, 12 to 18 months, 12 to 18 years, physiological changes, emotional changes, hygienic practices. So sexual development developing in women. We see breast buds developing, national average is between 8 to 13 years. We see in Adrenarch the growth of pubic hair. I spelled that wrong. And Menarche, seeing the onset of menstruation, the national average right now is 10.5 to 15 years. In boys, between 9.5 and 15 years, we see in testicular enlargement, pubic hair growth, increased muscularity, voice changes, and facial hair. Secondary sex characteristics, including voice alteration, facial and pubic hair, fat deposits, which play no part in their reproductive ability, but do cause some social awkwardness and the necessity of teaching children about these expected changes so they're prepared. Wellness promotion includes nutrition, rest, activity, and awareness of physiologic changes. Children and adolescents are capable of abstract thinking. They are in the stage of formal operations. So they are moving on to the possible related to experiences as opposed to real and actual from concrete operations. They're capable of scientific reasoning, so we see children at this age able to hypothesize. And then in Kohlberg stages, they are in post-conventional. Decisions involve moral dilemmas based on their internal set of moral principles. So they start to sort of compare their feelings to societal norms and thinking about their ethical stance. We see these formal operations for adolescents where they can reason abstractly and think in hypothetical terms. Sources of morbidity in adolescence include injuries and motor vehicle related accidents. This is when children are starting to be able to drive themselves, so that puts them at greater risk of motor vehicle crashes. Depression, eating disorders, substance abuse, sexually transmitted infections, pregnancy, and obesity are potential sources of morbidity in adolescence. This is where providing a safe, healthy home environment, eating and nutrition, a balance of activities, and safety, because we see these are the greatest risks for harm in this age, are going to be things related to home environment. They are involved in school and job. Eating and nutrition is of importance for them, and creating healthy expectations related to eating and growth and development. They are involved in activities. There's potential for exposure to drugs and sexuality. We see evidence of suicide and depression at this age. So one-on-one health screening is an important intervention to allow children to feel comfortable talking to their provider. Again, making sure this whole time we're looking at the left side, but you can read that for yourself. I do have some questions here, and I'm going to provide you guys with these questions and answers through my slides with the rationale. So if you have any questions about these, let me know, but I'm not going to go through these to read them for you. I hope this is helpful and that you guys can see it and use it, this lecture. Let me know if you have any questions, and good luck.